Bismillah ar-Rahman ar-Rahim. This is Dr. Muhammad Yassin, lecturer of anesthesia and intensive care, Cairo University. We will talk about the case of atrial flutter in our book, Clinical Viva. First, we will talk about the pathophysiology of atrial flutter. The atrial flutter is some sort of re-entrant supraventricular tachyarrhythmia. It is characterized by the specific sawtooth appearance of what's supposed to be the atrial activity. It may be regular, as we see here, and it may be irregular, as we see here. And this irregularity actually depends on the nodal activity or the degree of nodal block. The nodal block may be fixed as here, so it passes only one impulse for every 4 atrial activities. Or in this ECG, in the number B, there is variable block as it fluctuates from 4 to 1 to 2 to 1. Okay, so in one time it passes one impulse to 4 atrial activities, and the second one it passes one impulse for every 2 atrial activities. So most of atrial flutter are regular if the AV nodal block is fixed. But if the AV nodal block is variable, the atrial flutter may be irregular. Okay, so the atrial flutter is some sort of re-entrant supraventricular tachyarrhythmia characterized by fast heart rate, sawtooth appearance replacing the P wave and representing the atrial activity. There may be fixed or variable AV nodal block, and this defines if the atrial flutter is regular or irregular. Okay, like AF, atrial flutter actually can cause systemic embolization and shares the same management and the precautions as atrial fibrillation. Okay, so the difference between atrial flutter and atrial fibrillation actually is the mechanism of arrhythmia or the pathophysiology of arrhythmia. The atrial flutter actually evolves from different ectopic foci in the atrium, but the atrial flutter arises from single re-entrant focus, causing this sort of re-entrant supraventricular arrhythmia. And as we say, the atrial flutter may be regular and may be irregular like AF, but its regularity actually caused by the variability of AV nodal block. The risk factors causing the atrial flutter, most of the cases are idiopathic. Advanced age, one of the most important risk factors either for atrial fibrillation or atrial flutter. COPD due to chronic hypoxemia and pulmonary hypertension, which causes right ventricular enlargement and right atrial enlargement and so on. And this enlargement causes actually this sort of arrhythmia. Ischemic heart disease, which is accused for most cases of arrhythmias. Hypertension, diabetes, thyroid disease, and alcohol abuse. So the risk factors for atrial flutter or atrial fibrillation are idiopathic, advanced age, COPD, ischemic heart disease, hypertension and diabetes, thyroid disease, and alcohol. Why it's important for us to know the risk factors for this type of arrhythmia? Actually, for you to manage the arrhythmia, you have first to manage the predisposing factors. So if you don't manage the predisposing factor, actually it will be so difficult to revert this arrhythmia back to the sinus rhythm. Regarding the management of atrial flutter, as we said, it shares the same management of atrial fibrillation. The first part of your management is to manage the underlying pathology for you to make it easy for rate control and for reversion of the rhythm back to the sinus rhythm. So if you don't manage, as we said, the underlying pathology, you can't control the rate. For example, if you have a hyperthyroid patient and you are trying your maximum to decrease the heart rate and to revert the rhythm back to the sinus rhythm, actually you will fail and you will feel it difficult to do this because you don't manage the underlying pathology. So first, underlying management of the underlying pathology. Second is the rate control, and third is risk of embolization, and lastly is the cardioversion. Okay, and we will say at which stage we will do every step of this. Regarding the management of the underlying pathology, actually for the idiopathic cases, we will do anything. Advanced age, you don't have anything to do. COPD, you have to manage the hypoxemia and right ventricular hypertrophy and failure. Ischemic heart disease, you have to decrease the heart rate to increase the vascularization of the coronaries, either by vasodilators or by insertion of a stent or by CABG and so on. Hypertension, you have to control the hypertension and diabetes. Thyroid disease, by giving antithyroid drugs and beta blockers, and alcohol abuse to encourage the patient to give up this bad habit. Regarding the rate control, actually we have three categories of drugs, which is the beta blockers, calcium channel blockers, and digoxin. The decision to use which type of drugs actually is determined by the clinical picture of the patient. For the patients with arrhythmias, which is stable, and when we say stable, when we talk about the stability, there are different signs of instability when we are talking about the arrhythmias. First is the altered mental status. Second is the hypotension, when you have a systolic blood pressure less than 90 millimeters mercury. The third is the chest pain. And fourth is heart failure or pulmonary edema. So when we talk about the stability, when I'm talking about stability, I have to fulfill all these four items. So it's not all about the blood pressure. Actually, the altered mental status, chest pain, and pulmonary edema are signs of instability as well. So if the patient, when we'll come back to the slide, if the patient is stable, so we can use beta blocker and calcium channel blockers like verapamil, okay, because these drugs actually are negative inotropes and vasodilators. So these drugs will decrease the arterial blood pressure. So I can't give these drugs in a hypertensive patient. If the patient is borderline, his blood pressure is borderline, so I can give him digoxin instead of beta blockers or calcium channel blockers, because its effect on it has no effect actually on the arterial blood pressure, and in contrast, it's claimed that digoxin actually increases the cardiac contractility. Okay, so regarding the rate control, I have three options: beta blocker and verapamil. We will use this in a stable patient, and digoxin in a patient with a borderline arterial blood pressure. What we will do if the patient is unstable? What we will do if the patient is unstable, actually, that we will do cardioversion. And cardioversion is by chemical means or electrical means. And you should know that the electrical cardioversion is the one of a choice, because it's more than effective than the chemical cardioversion. Chemical cardioversion actually is done by amiodarone. The dose for this is 300 milligrams as a bolus for over 20 to 30 minutes, and then 900 milligrams over 24 hours. The electrical cardioversion actually we either buy the biphasic DC or monophasic. You start here with 100 joules, 100 to 150, and upgrades. And monophasic, you start with 200 joules and upgrades up to 360. Okay, if the patient has arrhythmias, for example, the atrial fibrillation or atrial flutter with hemodynamic instability, so you will do cardioversion, mainly by the electrical means. Biphasic DC shock, you start with 100 to 150 joules, and a monophasic, you start with 200 joules for 3 shocks. And these 3 shocks, every shock, you increase the joules up to the maximum for the biphasic, which is 200 joules, and for the monophasic, it's 360 joules. Okay. So if the patient is hemodynamically stable, so we will manage by rate control and digoxin. And if unstable, we will do cardioversion either by chemical or electrical mean. Okay. For the atrial arrhythmias, for the AF or atrial flutter, if the patient is stable, we said that we will do rate control. And then this is just a starting point. Then I will think about the age of the AF. If it is less than 48 hours, so I can do cardioversion, either chemically or electrically, the same way as unstable. And then I will give the patient anticoagulation for 3 to 4 weeks after the reversion of the sinus rhythm. Okay, and this is because after the reversion of the AF back to the sinus rhythm, actually there will be some time where there is some sort of electromechanical dysfunction. So the atrial activity actually will not come back as soon as I perform the cardioversion. So I have to give the patient anticoagulation for 3 to 4 weeks. If the AF age is more than 48 hours, then I have one of two options. Either to give the patient anticoagulation for 3 to 4 weeks and then give the patient the cardioversion and then give the patient the anticoagulation for another 3 to 4 weeks. The other option is doing a transesophageal echocardiography, which is very accurate in detecting thrombi on the leaflets of the mitral and tricuspid valves. If it is negative, so I can do cardioversion and then start anticoagulation for 3 to 4 weeks. Okay, so if the patient is unstable, I will give him rate control and then I will think about the age or the onset of AF. If it is less than 48 hours, so I will do cardioversion. The risk of thrombosis and systemic thromboembolism is minimal if the duration of AF is less than 48 hours. So I will do cardioversion and then give the patient anticoagulation for 3 to 4 weeks at least. And I will talk about what's at least after this slide. Okay, if the age or the onset of AF is more than 48 hours, then I will give him anticoagulation for 3 to 4 weeks and then cardioversion and then 3 to 4 weeks another anticoagulation. The other option is doing or performing a transesophageal echo if it is negative for thrombi on leaflets of mitral and tricuspid. So I will give the patient the DC shock, and I will give him anticoagulation for 3 to 4 weeks at least. Okay. What will define the duration that we will give the patient anticoagulation after the reversion to the sinus rhythm? Actually, the risk of embolization is determined by the Chadvask score. The Chadvask score actually is formed of if the patient has congestive heart failure, I'll give him a score of 1, hypertension 1, age 75, more than 75 years plus 2, diabetes plus 1, stroke or TIA plus 2, vascular disease plus 1, and age from 65 to 74 plus 1. If the patient is over 65, it will be given plus 2, and I will discard this item. Okay, and the sixth category is plus 1. Okay, so for the patient with AF and elevated Chadvask score of 2 or greater in men or 3 or greater in women, anticoagulation is recommended. I will give the patient this anticoagulation, this oral anticoagulation for life, even if the AF is reverted back to the sinus rhythm. Why? Because the risk of thromboembolism is very high in this category of patients if the AF actually recurs back to this patient. Selection of the anticoagulation therapy should be based on the risk of thromboembolism, irrespective whether the EF pattern is paroxysmal, persistent, or permanent. So, the anticoagulant therapy, as we said, if it is paroxysmal, if it is happened and I reverted it back to the sinus rhythm, and the patient has Chadvask score of 2 or greater in men or 3 or greater in women, I will recommend oral anticoagulation for these patients for life and not for 3 to 4 weeks. As we said, if the patient has a Chadvask score of less than 2 or 3 in men or less than 3 in women. Okay. Regarding the bridging therapy, this is very important point. If you have a patient who has AF and this patient is actually on oral anticoagulant and he's going for surgery, the bridging with unfractionated heparin or low molecular weight heparin is only recommended for the patients with AF and mechanical heart valve. Why this? Because the risk of bleeding actually is higher than the risk of embolization if you stop the warfarin or the oral anticoagulant before the surgery. So the risk of thrombosis is minimal regarding in comparison to the risk of bleeding. So when you have a patient on oral anticoagulant for AF and he's going for surgery, you will stop the anticoagulant. I will not give him a bridging therapy unless he has AF and a mechanical heart valve, because in this specific category of patients, the risk of thrombosis actually overweighs the risk of bleeding. So the decision on bridging therapy should be balanced between the risk of stroke and bleeding. So you have to balance this decision either with your senior consultant or with the surgeon, so you can weigh the risk of stroke and the risk of bleeding, and then you have to decide if you will bridge the anticoagulant with unfractionated heparin or low molecular weight heparin or not. But if the patient has a mechanical heart valve, you don't have an option, you have to anticoagulate this patient. Okay, this is regarding the atrial flutter. If you have any questions, don't hesitate to ask me, and thank you so much.